My name is Dena Reynolds. Today is September the 27th. I am in Nursing 2, and I will be doing a PowerPoint presentation over the GI disorder achalasia.
The esophagus is the tube that carries food from the throat to the stomach. In achalasia, also known as the cardiospasm, it is a serious condition that affects the lower esophageal sphincter, or also known as the cardiac sphincter of the stomach, because of its close proximity to the heart. Now, normally food goes down your esophagus and that valve will open up, allow food to pass through, and then it closes. Well, clients who have achalasia, that valve doesn't open up all the way, so all their food's not going. So food is getting stuck and it's causing pressure on their chest. It's causing a burning sensation, and a lot of people just think it's heartburn. Now, because the valve doesn't open up all the way, the primary symptom of achalasia is dysphagia. Achalasia can happen for different reasons, making it hard to diagnose. The condition may be hereditary or the result of an autoimmune disorder. The condition is rare. It has no known cause, though nerve degeneration, esophageal dilation, and hypertrophy are thought to contribute to the disruption of the normal neuromuscular activity of the esophagus. The degeneration of nerves in the esophagus is what often contributes to the advanced symptoms of achalasia. Although you can get achalasia at any time or any age, people who are middle age or even older are at a higher risk for the condition. It is more common if they already have autoimmune disorder, and in the advanced stages, the client will start to regurgitate, which will prolong the distension of the esophagus. Because the food is regurgitated, the patient may lose weight, they may become malnourished, have poor skin turgor, and overall body weakness. Now, your doctor may use esophageal manometry to diagnose achalasia. Now, this involves placing a tube down your esophagus while you take small sips of water. The tube then records the muscle activity, and it makes sure your esophagus is just functioning the way that it should. There's also a barium swallow x-ray that you can do, and this, you take the x-ray and it follows the barium down, and it shows the dilation of the esophagus, as you can see right here. Now, after they have confirmed the diagnosis of achalasia, there are a couple different treatments. Most of these treatments will involve the lower esophageal sphincter, which can temporarily reduce your symptoms or even permanently alter the function of that valve. Drug therapy, along with forceful dilation, is used. The medication for the drug therapy includes anticholinergics, nitrates, and calcium channel blockers to reduce the pressure. The pneumatic dilation, that's done first. You have to empty the esophagus, and then it's followed by inserting a balloon into the esophagus and inflating it. Now they'll keep the balloon dilated for a full minute, and this will help stretch out that muscle so food can pass easily. And this may also need to be done 1 or 2 times. You can also do Botox injections. Now, if they do a Botox injection, they will do it through an endoscope, and then they will inject that sphincter directly. Now, the dilation sometimes will tear the sphincter, and of course, if that happens, then they would need further surgery to repair that. Now, there's a couple different surgeries that they can do. One is the Heller's-myotomy, or is also known as the cardiomyotomy. Now, in this one, they will they go down into the esophagus. They'll make an incision in the muscular layer down to the mucosa, but not through the mucosa. Now, 2/3 of your incision is going to be in the esophagus, and the other third would be in the abdomen. This surgery allows the mucosa to expand. There's also the peripheral endoscopic myotomy, or what I would like to call the point, because I don't know how to say it. Now, in this one, they go down the esophagus. They make a small cut into the internal lining of the esophagus where another incision occurs to make it easier to swallow. Now, with this surgery, all the incisions are going to be internal. You're not going to have any external incisions on this one. There are 2 different types of esophageal spasms that can occur, and typically they're rare, but with some patients, they can occur frequently. The first one is the diffuse spasm, and it happens only occasionally, but it usually has the regurgitation with it. The nutcracker or the jackhammer spasm is more painful than the diffuse spasm. Although, despite the severity of it, it doesn't usually cause the regurgitation with it. Now, there's no known special diet for this, but of course there are certain foods that are going to irritate it and certain foods that are not. So small frequent meals, increase in fiber and water to help them not get constipated. They need to eliminate alcohol and tobacco. High calorie, high protein foods, just because if they're having a lot of regurgitation, they're probably going to be malnourished, and that way they will be getting the nutrition that they need. They need to sleep with the head of the bed at least a 35-degree angle to help keep everything down. Not to eat 3 to 4 hours before bed. And also, you can print materials that support those types of foods. That way they have something to look back on. Also, tell them to keep a food journal and write down what they eat. Not only what they eat, but the temperature of what it was. That way, if it irritates them, they can look back, see what it was, and maybe figure out which foods irritate it and which foods don't. Also, carbonated drinks. Yes, I said carbonated drinks. The carbonation seems to help push the food down helps push the food down the esophagus and into the stomach. So maybe they'll get a little bit more into the stomach than they would at a different time. You need to discuss the symptoms of recurrence or progression with your client, and they need to report any changes or any worsening symptoms to their doctor. It's also very important for them to keep their follow-up appointments. The surgical separation and the bag dilation permits the return of normal peristalsis in about 10% of clients. Now, September, here are some nursing interventions, but I believe I've pretty much covered all of them, so I'm just going to move on from that. Now, September happens to actually be Achalasia Awareness Month, so if you would, please share, hope, and raise awareness. Now, I think the most interesting thing that I probably learned with this process was I read that most doctors will not see a case of achalasia in their career, just from the fact that it's so misdiagnosed.